this meeting, but Dr. Kumar asked me to speak about what we are doing in Silchar, and I have tried to give it a lung perspective to sync with your meeting here. Ritesh is my colleague who does all the thoracic work at the hospital. Gayatri looks after our registry and helped collect all the data that I will share with you. Kapil is my colleague on the head and neck team, and Anuradha is our pathologist who have contributed to the frozen data that I will talk about. See, the challenges when we serve poor people, stems both from the patient side and from the hospital side. Now, from the patient side, most of them are actually afraid of hospitals. Many patients will not visit hospitals early because they think that if they go to the hospital, they will all be on the streets. And then there is lack of awareness about their options and their rights. They're afraid of a diagnosis of cancer. Many of them work for daily wages in our own setup. Almost 80% of them work for daily wages. And coming to the hospital time and again is a very difficult task. It almost makes it non-viable, to access treatment. Transport issues are there. They have faith in local healers. Then there are costs of care, their toxicity of treatment, and lack of local expertise. From an organization that is trying to provide inclusive care, we have to make the hospital, the services accessible, they have to be affordable, they have to be of standard quality. Just because we are treating poor patients doesn't mean we provide second-rate care. The treatment has to be provided in a respectful, hassle-free manner. It has to be equitable, it has to be efficient, it has to be universal, it has to be acceptable. But despite all of this, several times patients will not access the treatment. And so we have to ensure that patients actually take the treatment that they are supposed to take. We work in an area in the eastern side of Bangladesh, in the Barak Valley, in a town called Silchar. And like other places, we have our unique problems. There are places where it is very difficult to, there's no road transport, we have to trudge for miles. And when patients from these far flung communities have to be brought to the hospital, till they get access to the nearest rail head or road head, they will fashion a makeshift hammock out of and sling it across a bamboo stick, and they will carry the patient for miles till they get access to road transport. Several areas we have to, take boats to travel. But there is also, this is a place where Ronald Ross started his work. Ronald Ross got the Nobel Prize for his discovery of the malarial parasite in 1902. And he started his malaria work in a tea garden hospital about 25 kilometers from Silchar. The hospital is there, the laboratory is there, his hand drawings are there, the microscope that he used is there. And it is really inspiring to think that somebody just with his brains and a microscope could change the face of medical history. Typically, poor patients will handle out of pocket expenditure by selling everything that they can lay their hands on, by borrowing at high rates, and depending on public and charity from relatives, from hospital, from every source possible. So when we started building the services here, we resorted to a few. These now it looks as if we had a clear plan, but we resorted to proactively brand ourselves as pro poor. We started fast forwarding all our diagnostic workup and treatment. We resorted to a variety of cost reduction strategies, and we leverage technology extensively. I firmly believe that technology is the key to leveling the playing field between those who can afford treatment and those who cannot. And everything that we do must build confidence in the patients who come for treatment. So as part of pro-poor branding, we ensure that all our services, all our the hospital facade, everything is basic but clean. If we create, expensive looking infrastructure, marbles and tiles and paintings, it'll intimidate patients. Our body language, the way we talk, the way we hold ourselves must convey to the patient that they will be looked after. Because there are no frill services. We provide low cost, no cost services. We do not charge differentially because we strongly believe that if you charge a patient who can pay more than a patient who cannot pay, the patient who can pay will automatically start expecting privileges. And so they will be served first, they will be seen by the senior doctor, they will not have a waiting list, they'll have better rooms, and slowly, everybody will start catering to them, and a system that is designed to serve the poor without anybody's knowledge will slowly become rich focused, because the rich pay, they expect more. The doctor thinks that they are paying and they are subsidizing the cost of the poor, and so they deserve attention, and so the whole focus changes. We eliminate hidden costs as much as possible. We fast track all our target is patient comes today, by tomorrow evening the diagnosis, the staging, and the treatment plan must be ready, and then the patient will go back and decide and come. And we use our pharmacy, we use only generics wherever possible. We support boarding, lodging, and despite all of this, not even 30% of our patients were completing treatment. And over the last several years, we have learned every time we think of a new strategy, we think that is going to be the game changer. We started with providing ad hoc employment because most of them were daily wage earners. And so we thought by providing ad hoc employment, we will in some way compensate for their loss of daily wages. And then we created an appointment system where we would call every single patient who did not report for treatment and encourage them to come back for treatment. We started a home care program. We started visiting homes for in order to provide palliative care. We also started visiting homes of patients who were not coming back for treatment. And so, in by and by, we put in place a lot of measures. We eliminated all double charges. So patient comes for OPD, we have a one-time registration charge, and after that, no further charges for OP consultations. The same goes for physiotherapy, for dental care, for many, many things. And then with the onset of social insurance from the central government and state governments, made a big difference in our ability to reach out to patients. We engage very actively with the community. I will come to that in a bit. And now we have started a program to rehabilitate the families of patients where the breadwinner dies or is no longer able to um, take treatment. COVID was another opportunity when many hospitals shut down. Fortunately, we did not have to shut down even for a day. And that builds confidence in patients. We were able to carry out our home visits, palliative care. We also became the COVID cancer center for the district. And so we put in place measures for testing COVID. For a big hospital, these are all easy things. But for us, each of these turns out to be a major milestone. Over a 5-year period between 2014 and 2018, we saw about 850 lung cancers with evenly distributed numbers of adenocarcinomas and squamous cell cancers. Most of the patients are smokers, and there's a tremendous male preponderance to the occurrence of lung cancer. Now, the most of our patients are advanced stage disease. Almost 75% of them are in stage 4, and less than just about half of them complete prescribed treatment, and nearly a quarter of them don't even start any treatment. And out of these 400 or 500 odd patients that we treated, not even 1% of them were suitable for surgery, and obviously the survival rates are very poor. And so the thrust areas for lung cancer management in low resource settings is primarily to improve compliance. We must focus on the PEP, primary prevention, early detection, and palliative care. We must focus on hastening the rate of diagnostics. We must, of course, focus on cancer-directed treatment, but in a situation where an overwhelming majority presents with advanced disease and metastatic disease, the choice has to be thought about. We have to choose wisely about what we're doing. So we ran a pilot study in Kachar where we screened the entire health block, and we worked with the ASHA. The ASHA, most of them are 8th class, 10th class pass girls, and we taught them actually to use a tablet computer. We gave them a triage questionnaire to um, uh, collect data, collect information on patient symptoms, patient habits. We created a system where somebody is a smoker and somebody has a persistent cough. The patient will have to be evaluated further. The ASHA were also taught to screen for breast, cervix, oral cavity, and screen for diabetes and hypertension. And all of this happened in the homes of the population. Nobody had to visit an institution. And as expected, the compliance um, rose to uh, more than 95% in the program. Though we did not find a single lung cancer in this study, but it is a way to increase awareness in the community. The mathematics is in our favor. Each ASHA handles about 1,000 population, and the adult population will be about 600 or 700. And they can easily get access to the community, and they can be an invaluable vehicle for creating awareness for tobacco cessation, for palliative care. We are now training them to identify individuals in need of palliative care. So a whole lot of PEP activities can be worked out using frontline health workers in the community. When we started off, there were a lot of questions. The ASHA will not have time, so we did a time motion study and showed that the ASHA are engaged for about 12 days in a 26-day week month. And then, will the Asha be willing to do it? We ran a hands up question, hands up, show of hands, and overwhelming majority of Asha wanted to get involved in these programs. Ultimately, they're looking at incentive. Will the community accept them in this role? There was no problem at all. We did put in a lot of processes to get them accepted, but in the end, the community accepted them very well. And is screening possible at home? Whole lot of questions were raised. The Asha cannot do it. They cannot be taught to examine. We for all the ASHA were only taught to identify normal and abnormal. Anybody the ASHA said is abnormal was then examined by a health worker or a doctor, and only about 10% of the population had abnormal findings. Of those who were normal, 10% were rescreened by one of our doctors or health workers, and the concordance was very good. The other thing we did is for many years we didn't have a radiologist on in the hospital, and so we had all these biopsies that had to be done. We trained two of our CT technologists in doing image guided biopsies, and very good results. This is a comparison of a doctor done guided biopsy and the technologist biopsy, and most of the time the tissue is representative and the complication rates are very low. The other thing we did is, when we do conventional paraffin section pathology, it takes time, 2, 3 days. And then we have to do IHC, it takes a few more times. Sometimes we have to repeat the biopsy. And so this diagnostic process sometimes stretches to 2, 3 weeks. And poor people, daily wage earners will tend to slip through the cracks. So we switched over to frozen section pathology. In 2013 and 14, we actually replicated the process. Everybody had a frozen section pathology report and a paraffin section report. So in 2014, we did 880 histopathology examinations. 880 had frozen section, 880 had paraffin section. Only 68 times were the results indeterminate on frozen section, and in 20 patients the report had to be changed, just about 1% of the whole study. And so, we are able to start those who accept treatment within the first 7 days out of the 490 patients. 270 started treatment within the 7 days. They had their diagnosis, their treatment plan, and they actually started treatment in the first 7 days. And then the remaining started over the next 2, 3 weeks. Now, we leverage technology extensively, a variety of things, but what I would like to share with you is this concept of cloud ICUs. When we treat thoracic case surgery, when we do perform thoracic surgery, esophagus, lung, we need intensive care, and we don't have intensivists and critical care specialists in our region. And so what we did is we teamed up with these physicians sitting elsewhere, and we put these high definition cameras which can actually see the patient, record the monitor findings, transcribe it into a paper format without any human interference. A team of physicians, nurses sitting elsewhere watches patients and advises us. And you won't believe it, this patient had a ventricular tachycardia. The cloud physician spotted it. He alerted the nurse, and by the time the resuscitation process started, the patient arrested. Patient was revived. In the next few minutes, he arrested a second time. Patient revived a second time, connected to the ventilator. 5 days later, patient arrested again. And then patient revives, went home 2 days ago. This happened about 5 or 6 weeks ago. 2 days ago, the patient came to see us in the OPD. And so, we are now looking at putting up satellite hospitals in difficult to reach regions. And so we are planning to use cloud technology in order to reach critical care, in order to deliver dialysis for sick patients, in order to do many things over the next couple of years. Now I know I am into, trouble if I start talking about targeted therapy and molecular pathology because I know a lot of it is happening in lung cancers. But then we have to be circumspect about. I know there are situations where it makes an enormous amount of difference. Physicians keep telling me, lung cancer treatment has been changed. I'm sure it has changed for many patients, but for a vast majority, I'm not sure if it is going to make a big difference, and I'm not sure the cost eventually justify it. I had a school teacher from Karimganj. He and his wife, he had a metastatic adenocarcinoma. He went to some other place, and he was advised PDL1 testing was done. He was advised pembrolizumab, and the man sold every property that he had. A son who was mentally retarded. The woman had to take care of the son, and he sold everything, and then finally eventually he died. And I'm sure his life was extended by 2 3 4 years, whatever, but I am not sure as physicians we have actually done them any good. Now the wife is struggling to maintain the son and keep her living intact, and so as physicians, I know cutting edge technology, cutting edge drugs, targeted therapy, NGS, and PC, all of this is very exciting, but we have to be circumspect when we advise these to our patients. Every patient is different, and we have to get into the patient's shoes before we advise them many of these expensive therapies. They have their value. In due course of time, the cost definitely will come down. And so, while I would be happy to offer Jeftinib to any patient who mandates it, I would be very reluctant to think of other drugs. As a policy in the hospital, we offer first-line chemotherapy to all patients with metastatic lung cancer. But when they fail, we never ever offer them a second-line, third-line drugs. I know we can be criticized for this, but then this is what we think is best for our patients. Often, everything that I do, I cannot but think of Dr. Krishnamurti and Dr. Shanta, from whom many of us have learned many good things about patient care. Krishnamurti often used to say that if patients don't have the resources for their treatment, it is the job of the treating physician to find them. And the same vein, Dr. Shanta would often admonish us, everything for every patient. And I hope, as a team, all of us will be able to do that. Thank you very much. Thank you once again for this opportunity. Thank you.
Uh, Thank you, Dr. Ravi Kannan, for accepting this invitation. It was actually indeed an honor, to have you on this platform. Definitely, this is the first CRSF oration, and actually, we are very proud to invite you. Definitely, just remember two of my mentors. First is Dr. Kumar Prabhash himself. He will always tell me, if you want to do something, just do it, because there will be people who will always be complaining. So don't think you know what you can complain, but try to do things which are possible. And another is Dr. Maman Chetty sir, who used to say, if you want to do something, there are 100 ways to do it, and if you don't want to do it, there are 100 excuses for the same. So I think it's a perfect example for doing the things in the adversity. And definitely, I really salute you, Dr. R. Ravi Kannan, for your excellent work. And definitely, it's an inspiration for all of us. Again, I just wanted everyone to have a round of applause for Dr. R. Ravi Kannan, basically, for his exceptional work, definitely. And I
Thank you.
invite.
Thank you very much.
Yes, sir. You are most welcome, sir. And I invite Dr. V. Kannan, sir. He is consultant and head of radiation oncology unit from PD Hinduja Hospital, to give scroll of honor and to give vote of thanks. Over to Dr. Kannan.
Dr. Ravi Kannan. I am audible?
Namaskaram, sir. Yes, sir.
Namaskaram, audible, no? Dr. Ravi Kannan, uh, scroll of honor, I got a paper to read about you. I don't think that is right on my part to do that at all without telling. Unless until we come and serve the places like what you do, that is the best way the scroll of honor can be given to you, I feel. However, yes, I have to tell something about what you have done. And I used to hear a lot whenever I meet Dr. Shanta, whenever I go to Chennai to meet Dr. Shanta, every time she'll tell me and my wife, Ravi Kannan is there in Silchar, we need some help, we need a help, we need help. Every time she will tell that, we need doctors, we need that, we need that. I understand, especially the last slide, it is the job of the physician to provide it. Yes, Dr. Ravi Kannan, you have done it, Dr. Ravi Kannan. What they said, you have done it, Dr. Ravi Kannan. You are an excellent disciple. I hope what you told about Ross, the Nobel Prize, possibly waiting you soon. We, the fifth lung cancer year-end review participants and staff and the Cancer Research and Statistics Foundation have the proud privilege of felicitating you, Dr. Ravi Kannan, on this day, the 11th December 2021, for your immense contribution to the oncology, humanity, your passion for making the oncology treatment available for the common masses in a remote area of Assam's Barak Valley in Silchar, and converting the Catcher Institute into a beacon of hope for millions of people who suffer from cancer. Following your MBBS from Kilpak and your master's degree from Maulana Azad and your MCH from Adair Cancer Institute, you were in a very good position in 2005, 2006. You have nearly 15 years. You are heading the surgical oncology practice at Adair. You left everything, moved out to an entirely different place, a different language, a different weather, a very difficult terrain, a place with landslides, full threat of landslides. But Dr. Ravi, you have been the panacea to the cancer-affected souls of the entire southern Assam, entire Assam. And not only that, I understand that in Bangladesh, patients come over to you. So across the nations, across the countries, I think you have become the big hope for those people there. Your futuristic vision has turned the center into a full-fledged hospital. I understand some of the points you are telling, Dr. Ravi Kannan. The major thing, proper branding, phenomenal. I do not know. This is a major point for us to think about it. Brand yourself as Propua, all equal payment. Payments, patients who can pay. No, nothing needed to pay extra, and no extra services. All are treated equally. Ad hoc employment, something a phenomenal idea for the daily wage earners. Give them people who come with their relatives, you give an ad hoc employment and you're providing them money so that they also stay back. CT guidance, CT guided biopsy by the technologists. Phenomenal innovation again, Dr. Ravi Kannan. How you are able to manage it with an excellent results. Fast forward diagnostic facilities, cloud technology, you're establishing it, you're doing it in one of the most peripheral, one of the most backward area in the world. To that level, I can say, and you're using one of the most advanced cloud technology, molecular pathology, cutting edge, tailor-made based on the income also, not only on the technology available. Everything you have made so fine, Dr. Ravi Kannan, and you're running this hospital with very few resources. The hospital, under your guidance, also I understand supports cancer patients free of cost, including the family accommodation, employment center. Throughout the years, you have toiled hard to provide the best medical treatment to the poor, irrespective of the socioeconomic status. This has led to the development of very several innovative measures, which included what he told, like home visits, satellite clinics, and you are appropriately the medical messiah for cancer patients in the remote Barak Valley. We wish you many, many years of happiness. You may continue to be the angel of hope you have become to the patients of cancer. We want you to get many more awards. The awards will be happy to reach you rather than you trying to wanting to get the awards. And again, I say, the only way we can respect your lecture is we to come and serve them. Thank you, Ravi Kannan.
Thank you, sir. Thank you very much.
Once again, thank you very much, Dr. Ravi Kannan sir, for accepting our invitation and honoring us. And thank you, Dr. Mestri sir, and thank you, Dr. Kannan sir, for being a part of this wonderful oration. And actually, I mean, I really don't think so. I'm even worth to give the introduction. And I think you have a stature to explain all these things. Definitely, we would like to cultivate whatever the different values you have proposed, Dr. Ravi Kannan. And I think that is a success if we are having these orations. Thank you once again. From part
Thank
of
you.
CRSF, thanking all of you. Thank you.
Thank you. Namaskar.
Sure. So now we will have our next sessions. So I request Dr. Gautam Panda from Mumbai to have a next session coordinator.